overactive bladders was just reported at the AUA, and if you are looking at a boxing match, then Botox wins. Of course, there's a lot more to that story, and to tell us all about sacral and other forms of neuromodulation is my friend, the Hercule Poirot of urology, Carl Dietrich Sievert. What you may also not know that the BJUI is the official journal of the Swiss Continence Foundation. Now, this is my favorite superhero, and I remember weeping when Christopher Reeve sustained a spinal cord injury, and indeed he spent his entire life trying to find a cure for spinal cord injury in the form of regeneration. For the first time in the United Kingdom, you're going to have Mark Schneider from Zurich talk to us about an exciting new development which I clearly regard as having full potential, anti-NOGO-A antibodies and the spinal cord. And finally, for those of you who are our fans and follow the BJUI, this appeared in the spring as our article of the month. This is the Freedom Tower or the Azadi Tower in Iran, and this features a randomized controlled trial of underactive bladder in children. I know, speaking to Chris last night, that he has been to Iran, and he's going to give us, as the Secretary General of the EAU, an excellent update on overactive bladders. Gentlemen, welcome to BAUS. You have 15 minutes each, and then, if time permits, we will have some questions. Carl Dietrich.
Thank you very much for having us. It is a great honor to talk to you about what is coming up in neurostimulation. Also, it seems that there is not that much happening lately, but I will try to elude you a little bit what is going on. When we're thinking about the bladder, most of what we think is not realized by our brain, and most happens unrealized. And therefore, if there is something wrong with our bladder, and probably the most important thing is the Detrusor overactivity, is in coaction with the sensitivity and, after all, with the brain. If we look into the guidelines, we are usually asked what we can do after drug treatment has failed. So the next step, as suggested, would be the tibial nerve stimulation, and in the next level afterwards, we have to look into the options of neurostimulation or botulinum toxin, as Prokar already mentioned. We have seen already, and here some data from Thomas Kessler, Zurich, that if we inject botulinum toxin into the bladder, we have similar, as Claire Fowler has demonstrated, an effect to the CNS. From some of the studies, and that is going away from the suggestions of the guidelines, if we go into pelvic floor stimulation and we combine that with estrogen, we see that there is a certain outcome. And those patients demonstrate to have the longest efficacy if it is combined. And probably the estrogen locally applied is having this augmented effect to the overactive bladder. Another one is the magnetic chair. You might think this is not really something new, but the effect has been demonstrated. And usually the urgency is the one thing which is the most effective, but when you look into the studies, you see that the mean volume voided is increasing. Also, the average void over day is the same. Therefore, it does have an effect, but why do I mention it? A new study from Danny Eberle showed and looked into the animal model of the mouse that there is an effect in the early regeneration and that there is a lower inflammatory reaction, and afterwards the scarring of the trauma is less. So therefore, it probably enforces the reorganization and hypertrophy of the muscle which has been injured. And that might be a new way to have a better healing after injuries at all locally. As I mentioned already, in the situation of the posttibial nerve stimulation, we are getting closer to the invasive possibilities we have. When we look into analysis, there is not much, but we do know that it is active, helping in OAB. But only 4 randomized studies, and gradually has demonstrated, have been really controlled, and it became a level of evidence number 1. To take that a step further, I think it was important to look what the neurogenic group is doing. There we have at least 9 prospective studies, but still the evidence is low for those patients. I think one of the most interesting papers came out of the group from Chapter Growth. 8 healthy volunteers received tibial nerve stimulation for 19 minutes. They had a bladder diary 3 days prior, and then they had the stimulation, and the most interesting thing is the validation of the effect to the bladder. The bladder capacity increased for a certain time around 200 ml, from 350 to almost 550. So therefore, it was demonstrated that there is an effect which is carried on in this healthy volunteer group for 36 hours. So we have to think what to do. We started a few years back, 2014, with the first patients to have a chronic implant, which might be a new way to go and not any longer to have them as outpatients keeping us busy over the day. So the implant is done through this very small incision of 0.5 centimeter, and it looks like this in the X-ray posttibial. The effect on the first patients we did was tremendous. They had, beside neurogenic problems, nocturia, which disappeared within 2 days. Now we are doing 2 study sites in Salzburg and in Belgium with already over 10 patients. We have to wait for the outcome. Another site who is doing that with a little bit more invasive surgery is the Blue Wind, which is supported by Medtronic, but John Hesacker is doing that with other colleagues, and they have implanted 35 implants and have quite an interesting outcome. But on the other side, I think personally, it is more invasive than it should be because you have to open up the lower leg in the way as demonstrated. Looking into that, obviously it becomes more interesting to see what might happen. So for sexual function, it might be a new way to improve that. On women who had OAB dry, 50% were looked at and they fulfilled the criteria of female sexual dysfunction. And over the time they had the PTNS, it was found out that they improved significantly. So maybe another way to improve on the side of dry OAB, the sexual functional situation. But let's shift back to sacral nerve modulation, which is the classic one and very open to all of us. The workflow for sacral nerve modulation is different in different countries. Some of them are going immediately to the sacral nerve modulation step 1 and 2, or they're still doing P&I as I love to do it. But what I think we need to do, not only to see the improvement of over 50%, but I put it to 70%, and in the long-term run, the success seems to give me the right outcome because we do not have to revise so many patients. But in Salzburg, a new setting was coming up, because we saw that only probably 65 to 70% of the patients are receiving an implant. And what is happening with the other ones, with the negative outcomes, those which we cannot place an electrode, if it is the chronic one already or the P&E? We verified the protocol and went with those patients into the CT scan and placed the electrode there. And it seems that this is a new way to look into the opportunities because the success rate was 90%. So we have to look into those patients who failed in the first run, and maybe they will do better with a CT guidance. The outcome was not only that they were a success, but we also are able to decrease the amplitude needed, average to 0.5, and the outcome was improved. Well, Proka already mentioned the comparison between botulinum toxin and sacral nerve modulation. And of course, I was asked to talk a little bit about the outcome for the sacral nerve modulation. Different aspects looked at here, but if you see this, in the long term, it seems to be a success for the sacral nerve modulation. Also, the group, bottom line, of micturated volume seemed to be worse to start with, which is the normal way because the patients usually receive neuromodulation later than they would receive sacral nerve modulation. But the success over time and not the need to redo it seems to give this the right position. And compared in the ABC trial, demonstrated that botulinum toxin seems to be likely, at least for the bladder, and the quality of life similar to antimuscarinics. And therefore, with the side trial, it was demonstrated that the improvement with sacral nerve modulation seems to be better. Let me take you back a few years when we looked into spinal cord patients and we tried to apply with bilateral sacral nerve modulation to see how we can improve the outcome for this high spinal cord patients with an expected DSD. We were able to avoid the Detrusor overactivity. But in the group of Salzburg, we went a step further. And we had the situation to look into the animal model again. Just spinal cord injury with a ballooning on the spinal nerve, and then either sacral nerve modulation or a pudendal nerve stimulation beside the control. The awake animal was undergoing urodynamics on and on again. Here are the results. On the right side, just the urodynamics of a spinal cord injury with a decreased bladder capacity and the leak point pressure, whereas the sacral nerve modulation increased the bladder capacity, which is confirming what we have seen in the patient, with a similar leak point pressure, whereas the situation for pudendal nerve stimulation seems to be very similar as if you have done nothing. Looking then, and this is the opportunity we have, not only into the situation of urodynamics, where we were able to see an increased bladder capacity, as I have shown you, but also an increased outlet leak point pressure, we looked into the histology. And I think it is astonishing to see with sacral nerve modulation, which is insignificant different to the normal healthy animal bladder wall. We were not able to do in an awake animal the urodynamics. That's why it is a little bit difficult to show you that data. But what is astonishing is the next step we did. We looked into the spinal cord where we had the compression model on TH11 and 12 and wanted to know what is the effect there. And with this, we had to look into the dorsal horn and analyze that with MAP, NFH, and DAPI. And the result was astonishing for us, and I guess also for you, because with those areas below stimulating with sacral nerve modulation, we had an increased situation compared to sacral nerve modulation and pudendal nerve stimulation or not doing anything. So maybe this is a hint that sacral nerve modulation might be effective for the overall. So with the nerve stimulation in this animal model, we are able to demonstrate that the changes in the detrusor by itself can be avoided or delayed, and that there is a spinal cord situation which can be influenced, and new models and further steps in this model are on the way. On the other side, we know already, and they have been shown, smaller implants for IPGs from different companies, but probably with the same kind of electrode which we were facing already in clinical situation, which are having the problem that they might be dislocated over time, especially in spinal cord patients, and start to move. Therefore, we are happy that we are able now to have a new electrode which hopefully will avoid the movement in the sacral nerve modulation. Coming back, what is important for our patients? I think one paper came out last year from Linda Cardosa, asking patients what they would like to have and in which following. On the right side, you see what they have compared with the literature before they went to ask the patient themselves. So they made a cross-central web survey and looked into that, and they got a feedback of 77% of females and the rest of males in 140 patients. And it came out that most of these patients would prefer tibial nerve stimulation above sacral nerve modulation and then botulinum toxin, which seems to be surprisingly. But I think we have to keep that in mind when we make our decisions with our patients in which setting we want to run in the ongoing situation. And on the other side, we have to keep in mind that neuromodulation and nerve modulation is a circle between the brain and the end organ, which we want to influence. Thank you very much.
Excellent, and bang on time. Next up, we have Mark Schneider from Zurich and the Swiss Continence Foundation to tell us all about anti-NOGO-A antibodies. If this does not excite you, I have no idea what will. Mark?
Thank you very much. After spinal cord injury, bladder functions completely out of control. In particular, Detrusor sphincter dyssynergia is greatly feared because it puts the upper urinary tract at risk. Currently, there is no causal treatment option available. I'm also looking with great interest towards electrostimulation therapies, and thank you very much for a great presentation, Katie. So this may also be something very interesting, but just saying at the moment there is no causal treatment option available. And for whenever you want to go towards new treatment options, you need first to understand the spontaneous spinal regeneration, and after that you can then go towards treatments and try to modulate that. So that's why I've structured my presentation into two parts. First, spontaneous regeneration, and then I will focus on a potential first treatment option, the anti-NOGO-A antibody. I will mainly talk about unilateral hemisection spinal cord injury models, and the spontaneous plasticity after this injury is actually interesting because you have a very good functional recovery in rat animal model of the hind limb locomotion, but the precision movements are very poor regenerated. So first we needed to investigate which tracts are actually mainly innervating the hind limb function. That for retrograde tracing was performed in lumbar segments, and with that we were able to label all the innervating neurons in the brainstem and the cortex. And what you see interestingly is actually that the reticulospinal tract seems to be the key player with about 70% of neurons. So that's why we were mainly focusing on the reticulospinal tract for the next studies. So regenerative sprouting of reticulospinal tract was observed after a unilateral hemisection of the spinal cord. We have performed anterograde tracings into the reticulospinal tract and were then able to label the fibers above the lesion. And what was observed actually is that you have a massive increase in sprouting activity of the reticulospinal tract just above the spinal cord injury compared to control animals. So reticulospinal tract sprouts above the lesion. But the question is now, what do these sprouts do? That an additional study was performed by Anne Engman and Leonard Fili, and they injected additional to the anterograde tracers retrograde tracer just below the injury, and they were able to label, you can see it here, that you have connections, synapses between the two traced neurons. And the question is a bit, or was in the beginning a bit, what kind of neurons are this? So what you can say already is that they were propriospinal interneurons, just because of their appearance in the spinal cord. But the question was, why actually are they labeled? If you inject the tracer below the lesion, there has to be side switch actually of those propriospinal neurons, and that was actually also observed then by counting the midline crossing fibers of those propriospinal interneurons. Below the injury, you could see that those propriospinal interneurons, they recross the midline of the spinal cord injury, and this was observed in spinal cord injury animals compared to control animals, and there were significant differences in those midline crossing fibers. So in conclusion, for the reticulospinal tracts, one can say that after spinal cord injury, they start to sprout massively above the injury. They form new connections to propriospinal interneurons, and very interestingly, those propriospinal interneurons, they form detour pathways around the spinal cord injury by recrossing of the midline. So, but there is also a second mechanism which may contribute to this very good locomotion recovery of the spinal cord injury, and these are actually from the intact side fibers which cross the midline below, and they are also believed to participate or contribute to the hind limb function after a unilateral spinal cord injury. So, summarized, one can say that this regeneration is mainly basing on formation of detour pathway with sprouting of the reticulospinal tract fibers above the lesion, sprouts which build synapses to propriospinal interneurons, which then detour the spinal cord with a re-switch, with a side switch below the injury, and an additional mechanism is probably the side switch across the spinal midline of the intact side from the reticulospinal tract. So now the question is a bit, when we go towards neuro-urology, what are currently the main questions? And I would state that at the moment, at least in my research part, the development of Detrusor sphincter dysenergia is very important, and we would like to understand actually why does this happen, and we have split up that a bit with other questions like how does the spinal circuitry react actually if you take the cortical control away, and also how do spared descending fibers react? Do they build new sprouts, new reconnection, and what's the specificity? And also, can we influence this process by nerve growth promoting therapies? I won't have time to talk too much about this ongoing project, but I would like to focus on the nerve growth enhancing factors, and therefore I would like to introduce 4 different approaches how one could try to enhance nerve growth. First is by counteracting actually the growth inhibitory factors. Anti-NOGO-A antibody that I will talk on later is one of those. Then one could think of growth inducing factors. There are some available. Then by upregulation of growth regulation, this is also an approach, and also interesting stabilization of cytoskeleton. But however, I will focus now mainly on this part, and I would like to talk a bit about NOGO-A. So NOGO-A is a protein which actually stops growing of nerve fibers. You see on the left side growth cone. This is cell culture, and you have seen that this axon was growing, and the growth cone collapsed after a while. This was because of contact with myelin, and myelin contains a lot of NOGO-A, and NOGO-A is actually reducing nerve growth and causes collapse. However, if you put to the same culture anti-NOGO-A antibody, which blocks NOGO-A, you can see that the growth cone nicely grows. So what's the mechanism of this growth cone collapse? It's actually by depolymerization of cytoskeleton, actin filaments, and if you would let this cell culture run now for a while, you find that anti-NOGO-A antibody treated cell cultures, they have much more fibers which are actually built, and also they stay there, compared to control antibody treated culture in the middle, and on the bottom no antibody culture at all. You see not a lot of sprouting. So this was now all in vitro experiments, and just short about the NOGO-A signaling. NOGO-A is actually a protein which is present on oligodendrocytes, and it binds to NOGO receptor 1, and it causes, over Rho-ROCK kinase activity, a collapse of cytoskeleton, and thereby the growth cones collapse. I don't want to bother you too much with that. More interesting and more important is actually that those mechanisms have been also shown in vivo experiments. Here in a rat spinal cord injury model, on top left side you see control antibody treated animals do only have very limited number of sprouting fibers after spinal cord injury, whereas compared to two different anti-NOGO-A antibodies which show actually massive increase in sprouting below the spinal cord injury. But the question is now, are those sprouts also functional? And yes. So this was another experiment where the rat was placed on not a running wheel, but for the locomotion gait analysis, and you see kinematic analysis of the walk of the animal, and what you see is a nice homogeneity in the walk, whereas control antibody treated animals after spinal cord injury, they are very poor, they have a lot of dragging compared to anti-NOGO-A antibody treated animals at the same time point, where you see actually very nice, very homogeneous, I would also say a precise movement after spinal cord injury and anti-NOGO-A antibody treatment. These results were also proven by monkey trials. So same lesion and control antibody treated animals versus anti-NOGO-A antibody treated animals, and you see massive more sprouting below the lesion in the monkeys which were treated with anti-NOGO-A, and very importantly, the precision grip in the anti-NOGO-A antibody treated animals was massively increased compared, those are the red animals, compared to control antibody treated animals. So with this knowledge, Novartis and Martin Schwab went then in 2011 into a phase 1 spinal cord injury safety trial with a first human anti-NOGO-A antibody. This trial included Asia A patients, 52, and they got intrathecal injections of the anti-NOGO-A antibody. But this was phase 1 for safety, pharmacokinetics, and dosage. But this was successfully finished. However, Novartis then changed the strategy, and they've reduced the entire neuroscience part in Europe. And due to these changes, Martin Schwab then went on with an investigator-driven study. So he went for searching money for funding in university environment, and therefore he got now a Horizon 2020 grant, which finances the first phase 2 trial in spinal cord injured patients, which will start end of this year. It will include 150 patients, Asia A to D. It's a multi-center study in Europe, and very importantly, it will include urodynamic investigation within the first 40 days, 3 months, 6 months, and 12 months after spinal cord injury. So there are also other companies which are actually investigating anti-NOGO-A antibodies as potential treatment option. GlaxoSmithKline has an anti-NOGO-A antibody which is investigated in MS and amyotrophic lateral sclerosis, and there they have started the phase 2 already. They use IV injections of the antibody, and also Biogen has an anti-LINGO-1 antibody, which is actually the same mechanism of action, but just another area of blockage. It binds the NOGO receptor. So, and they're already in a phase 3 at the moment. One could conclude, NOGO is on the go. So, I would like to thank Martin Schwab. I'm currently a PhD student at his lab, and the data I've shown is from many students from his lab, and I would like to take the chance to introduce the 5th International Neuro-Urology meeting, which will actually take place in Zurich, Switzerland on 26th to 28th of January. So we would be really happy if you would join that meeting and one could further discuss. Now, how I am in time?
Perfect.
Perfect. Okay.
Come and take a seat. There is renewed interest in Detrusor underactivity. I thought the whole story had died a death, but here to tell us about that renewed interest is Chris Chappell. Chris?
Thanks very much, Prokar, and thanks for inviting me. It's a great pleasure, and I must congratulate BAUS on such a fantastic meeting. So, the underactive bladder. I have worked with industry, and this is just disclosures. This is a colleague, a young urologist in the UK. He's done a lot of the work with me in this area. It's very important when you're thinking of anything to define what you're talking about. I'm sure we'd all agree. And I'm going to cover these different aspects: terminology, epidemiology, etiopathogenesis, diagnosis, and subsequently management. And of course, we all appreciate that there are a number of lonely tract symptoms, both storage voiding and post-micturition. At the end of the day, these symptoms are certainly not disease-specific, and patients describe them in very different ways. And as urologists, we all interpret them with our own individual baggage and bias. Of course, it's very important, therefore, to define what you're talking about, and the ICS has always looked upon this using the algorithm of symptoms, signs, urodynamics, conditions, and treatment options. And in this context, of course, if you look at terminology, you need to interpret the words with that baggage behind you in terms of what the words really mean. And of course, there are a lot of terms that have been applied to the underactivity of the bladder, and of course, the only one that's defined is Detrusor underactivity, which is, of course, a pressure flow diagnosis based on invasive pressure flow urodynamics. The question really is, could you have a symptomatic diagnosis of the underactive bladder which has a similar relationship to that which you see between overactive bladder symptom complex and Detrusor overactivity? Is it possible, therefore, to have this relationship? That's the question. The problem, of course, if you look at the literature, is there are a number of symptoms which relate to Detrusor underactivity, both storage voiding and post-micturition. And that's no surprise to a urologist. Of course, if you look at the various symptoms, therefore, if you try and make a symptomatic diagnosis, is it feasible? Is it helpful? Does it aid the treatment of patients? Well, of course, the problem is with underactivity, you may have urgency, you may have frequency, you may have nocturia, you may have difficulty voiding and retention, and so on. Now, this has been looked at by the group in Bristol, as you can see in this recently published data. And here they looked at, of course, the relationship between Detrusor underactivity and normal in terms of symptoms, and mostly it was voiding symptoms. If you then looked at this context versus obstruction, you saw other symptoms come into play, and no surprise there: retention and incontinence and so on, with chronic retention and overflow. Now, they've then followed this looking at the concept of PROMS. And this is a definition I was involved in drawing together recently, which is a working definition which is being adopted by the ICS as a basis for further investigation. And they looked at 47 consecutive patients, looking at the concept to try and define what patients actually understood when they had various urodynamically defined abnormalities. And you can see there was Detrusor underactivity and also patients with obstruction. And you can see Detrusor underactivity with other existing problems. Now, the conclusion that they drew is that the patients actually have very clear views about what they want, and of course there's no surprise there, and this has formed the basis now for ongoing work where they're drawing together a validated PROM which could be useful in this context. The definition I alluded to was that underactivity is related to these symptoms in particular: a slow stream, hesitancy, and straining to void. And the problem with that, of course, is that's not very specific. If you then move on to the storage symptoms, of course there are many other reasons for that. And one mustn't forget that gender, age, neurogenic abnormalities, and of course specific tests which we can use in clinical practice are all relevant in this context. So really, if you're referring to the definition, we need to now look at qualitative and quantitative aspects for the future. So that's where we've got to in 2016. In terms of diagnostic tests, of course, We all know what normality is. We all know the importance of urodynamics in this context. And for given Detrusor contraction, it's very important to look at the outflow as well as the bladder function. Now, it's like everything. You can tell when somebody's got underactivity on urodynamics. It's very clear-cut, a low pressure, a low flow. But the problem with this, of course, is what is the contractile strength and its duration, and how effective is the bladder at emptying in this context. The acontractile bladder is even clearer, of course, but the problem here is, can you actually exclude somebody who's got bashful voiding during a urodynamic test? And of course, you need to look at the various differences between Detrusor underactivity and acontractility. Of course, Derek Griffiths is the father of urodynamics in terms of concepts, and all of the concepts are based on the work that he did in the context of physics. And the basis for looking at the outflow tract and function in this context is looking at Detrusor pressure against flow and the pressure flow algorithm, which we're all familiar with, which is now the ICS algorithm, where you can subdivide obstruction from poor function and normality. Now, obviously, if you look at the PDET Qmax, this is often used, and it's very useful, but there are a number of uncertain aspects relating to strength, variability in bladder outlet, and what is the normal range. That hasn't yet been defined, although this is accepted to be the definition: less than 40, an unobstructed patient, equivocal of 20 to 40, and more than 40 obstructed. So clearly, the next step on from this is to look at the power within the bladder, the Watt factor, which is derived from that, based on this rather complex algorithm. And again, the ICS has defined this, and you can see how this relates to the other pressure flow characteristics. Now, the next stage on, of course, is to look at the projected isovolumetric pressure, and related to that, the contractile index and the derived bladder coefficient. We're all familiar with the isometric pressure during the stop test, during voiding, and the calculation based on that, which is different between men and women, where the actual variable used for men is ×5 and women is ×1, bearing in mind their outlet resistance. And you're all familiar with the range defined by the ICS and been around for a number of years, where strong Detrusor is more than 150, a normal is 100 to 130, and a weak one's less than 100. Now, obviously, there are other tests that you can use in the male, such as the plethysmography test, and of course, you can use a mixture of these in defining patients, but pressure flow urodynamics remains the gold standard. Now, the problem with epidemiology is it's completely unrealistic to use these tests in an epidemiological setting. And of course, we're therefore reliant upon symptoms which are not disease-specific, as I've mentioned, the flow rate, the post-voiding residual, and of course, patients with urinary retention. This is the world literature as it stands at present, and this is really a summary of that in fact Detrusor underactivity increases with age in both men and women, and does affect up to a quarter of the population or more, of course related to age. So it is a significant issue, although hopefully it's not going to cause major problems in the majority of people. And indeed, analyses based on symptoms, which have their deficiencies of course, show this to be the case, 23% in this recent US study, and another one again, 23%, published quite separately. So etiopathogenesis. Of course, it's a final common pathway, the bladder, as we've heard from the two previous excellent presentations. There are a number of issues. So let's start peripherally. Of course, the first thing to bear in mind is that the obsession we've had with Detrusor muscle in the past is certainly not the focus for attention. With all therapies at present for overactivity, we focus on the urothelium and non-neuronal release of neurotransmitters. The suburothelial space is probably the target for all the therapies we use in clinical practice. We're reliant, therefore, on the afferent pathway, symptoms going back to the brain being processed by the limbic system, the emotional centers, and of course the principle is that whilst you're all sitting there, this is happening, but it's not reaching your consciousness. And all the time, the limbic system is producing inhibition of the pontine micturition center until permission is given to void. Again, one sees this with the key in the door phenomenon, when you get home with a full bladder, and then when you're given permission to void, the bladder empties itself. So at the end of the day, if one's looking at etiopathogenesis, one's got neurological injuries, idiopathic problems, of course, for many things in medicine, functional abnormalities, Fowler's syndrome, dysfunctional voiding. Muscle disorders, of course the muscle's important. If the muscle's had it, you're not going to contract the bladder. Pharmacology, drug therapy people are on, affecting central and peripheral function. And of course, you've got the iatrogenic causes with major surgery leading to denervation of the bladder. So you've got central, efferent, afferent, and motor problems. You've got all of these aspects, failure to stimulate the bladder, failure to contract, failure to sense, and failure for the muscle. And again, at the end of the day, the common problems, of course, neurological, diabetes, blood outlet obstruction, and of course, in many patients, what causes chronic retention, we don't know. They just appear, don't they? Often, they must have an underlying long-term abnormality. So that's where we stand at present. We really don't know an awful lot. We do know that there is a sensory problem. This is recent work showing this with underactivity, and this is work that's ongoing and which we're also involved in. The problem in the whole field of urology, whether it's overactivity or underactivity, is unfortunately none of the small furry mammals help us. Primate work, like we heard, is essential because all of these animals have a non-adrenergic, non-cholinergic innervation for at least 60% of the function, and no drug has ever been developed in the field of functional urology based on an animal model. If you think on that, you'll recognize that is true, or do tell me if I'm wrong. So that leaves us with management. Clearly, drainage of the bladder by intermittent self-catheterization is the most commonly used approach. There are others, of course, which can come into play. At the end of the day, you either want to increase the power of contraction of the bladder or reduce the outlet resistance, or, of course, circumvent the process with a catheter. Behavioral therapy, straining, physiotherapy of this pelvic floor spasm and catheterization are clearly the commonly used techniques. But at the end of the day, I think the more experienced people get, they realize that just because there's a large residual, as long as the bladder isn't low compliant or overactive, you can maintain patients with large residuals, and we've all done that and do it. And here's some evidence from Bristol over a 13-year period where very few patients, just around 11%, went on to any form of surgical intervention, even with residuals of 300 or 400 mils. So very clearly, conservative management is appropriate in many patients. Catheterization, we're all familiar with the different techniques and the downsides with this and the unpleasantness to the patient. Drug therapy, as it stands, cholinergic agonists do not work, and indeed have been abandoned by most people because of the side effects, because they produce a mass contraction of the bladder. Of course, electrical stimulation locally in the bladder has been used in the pediatric population, but really isn't tenable as a long-term therapy. And of course, we're familiar in spinal cord injury with patients having electrical stimulation, the Brindley stimulator, and other such approaches. Again, of limited benefit. The question is whether sacral neuromodulation can be used, and there is work, and KD's been involved in this as well as others. And here is some published work I came across, and you can see they looked at 18 patients, but those where it worked, surprise, surprise, were the patients where there was reasonable detrusor contraction. And again, that was demonstrated by another group where they showed about 50%, where there was reasonable detrusor contraction. There may be some benefit, but the underlying urodynamic assessment, first off, is important, looking at the Watt factor and so on. So in terms of surgical intervention, people have tried different things. There's been a lot of interest in, for instance, helping nerves by producing grafts and so on. But again, as you know, this is rather contentious with variable literature out there. But obviously the technique we've heard about facilitating growth of nerves may actually be a landmark development, and time will tell. There's also been work that K.D. Sievert's been involved with Arne Stenzel from Tübingen and before from Innsbruck. And there's a recent multi-center study which has looked at this. But the point to make is it's a very select group of patients where you can actually use a detrusor myoplasty using the latissimus dorsi muscle, which has got a single artery and nerve that you can actually implant, because it's lengthy surgery involving 2 surgical teams, and where you can actually, as you see in this patient, get a benefit in patients by this very complex surgery, but it's not without its complications. And at the end of the day, for a very select group of patients, and probably not widely applicable outside a very specialist setting. So they concluded that with a very selected group of patients, they could get an 80% or more benefit, either significantly improved or improved, and 91% of them were without infections and had reasonable long-term follow-up. in multi-centers, 3 centers involved in this study. So to conclude, Detrusor underactivity is a common problem. It increases with age. There's little published clinical or scientific research in this area. Drugs are currently being developed based on the prostaglandin approach, and a definition needs to be put forward and tested, although it may not be feasible outside urodynamics. It's multifactorial in etiology, and there's a lack of simple and effective treatment in this area. Last, forgive me, but I must congratulate BAUS on what they're doing and thank them also for the strong link that they've established with the European Association. And of course, we're hosting this meeting next year in London. Thank you for your attention.
Time for questions. Anyone got any questions from the floor? I see Professor Shamim Khan. Microphone 2, please.
Chris, brilliant presentation. All the presentations were excellent, so many questions. But may I ask you, many of these patients who present with bladder underactivity are quite young, in their 30s and early 40s. So how do you follow them up, and do you investigate them neurologically, whether they could have underlying neurological problem?
Personally, I mean, I don't know how this... It's on now, I think. Thanks. I mean, personally, if a patient presents with this abnormality where there's no other explicable etiopathogenesis, we'd also always do an MRI scan. We'd probably get a neurologist to have a look at them. But in most of them, you can't find a cause. And in this context, then, the urodynamics is important. If it's an acontractile or low-pressure bladder, I tend to be rather conservative and avoid catheterization unless the residual is well over 40% of the functional capacity. And again, it's age-dependent, and it depends on the level of symptomatology. Many of the patients are very symptomatic, so you have to do something. And in this context, of course, CISC is probably the best treatment option for them as things stand at the moment. But obviously...
Some of these may not have much residual, maybe 30, 40 mils may not...
Well, I do nothing in that context, to be honest. I think that the least intervention, the better. And if they've got a residual of just 30 or 40 mils, there's likely there are other causes for their symptoms.
Thank you.
We got another question.
It's on the same point, and can I congratulate all the speakers? What a terrific session. It's really to follow up that point in the younger patient that we often see. How diligently should we be looking at urethral function to see whether in fact it's that the urethra won't relax rather than the bladder won't contract?
Shall I say something then my
Please.
colleagues could speak? I mean, I think that the problem with urethral function is I find it very difficult to assess. I think urethral closure pressures are very dependent on the center and the technique used. And to be honest, I've gone off using them a lot because I've not found them as useful as initially, earlier in my career, I found them to be. So I tend to play it by ear based on the residual in these patients and their symptomatology. Because at the end of the day, I think it's very difficult to deal with a spastic outlet. If it's Fowler syndrome, which as you know I was involved with Tim Crispus and Claire Fowler in describing when I was at the Middlesex many years ago, that obviously there it's difficult to do CIC if they've got a bladder outlet obstruction, because the catheterization hurts like anything. It's almost a diagnostic test. And there, sacral neuromodulation may be helpful, because there's evidence from from Griffiths and colleagues in Pittsburgh that sacral neuromodulation actually gets rid of an inhibitory reflex which seems to be present and works very well in a proportion. But in the remaining patients, physiotherapy may be helpful. Particularly in the male in this country, we see prostatidynia, or abacterial prostatitis, and certainly interestingly in the Far East, there's an increased prevalence of similar voiding dysfunction in women, and it's probably stress-related because of the high pressure people are under. So physiotherapy, relaxation, other such techniques are useful. I don't know whether I've answered your question.
Well,
that's the view I have.
I agree exactly, and that's of course what we all do, but isn't the evidence coming through that a lot of these people are chronic opiate users? I don't mean in a bad sense, I mean in a medical sense. And the next question is, if they stop the opiates, does the function get better? Because I don't know.
My colleagues.
So I have some thoughts on that, but Katie, are these are a number of these patients opiate users?
Well, it is very difficult to find out what they're using, and they deny it for a long time. Sometimes you get it out, or they come with the information. I got to the point that neuromodulation is one of the best ways to really look into that. That's why I prefer like P&E over a time. It is, as you defined it, if the volume they are voiding is large or the bladder capacity is large, but the residual is small, I would not do anything. But we have to check them ongoing to see if there's a shifting suddenly and the residual is picking up. Because that is the point when usually, and those are males, are having an enlarged prostate or prostatitis or something like that. And sometimes it's a bladder neck, and there I started to tend to do like a Botox injection into the bladder neck, because it seems that there is also one of the parts, but that is not proven, and the cases of numbers are very small.
So unpublished data from Queen Square actually shows that there is an association with opiates, and that reducing opiates, which is very difficult in some of these patients, might help a segment of those patients, not all. So some of them, despite reducing or discontinuing opiates, actually do not regain their function. So there is unpublished data. I'll check with Queen Square as to whether they are due to publish it. But thank you for bringing that up.
Can I just comment on the Botox injection? I think the evidence from injecting into the prostate is that it didn't work for prostate obstruction. And if you look at the Dijkstra work and the Church work and so on, there's no defined dose for injecting into the urethra or the bladder neck. And the evidence is it suggests it lasts for about 30 to 60 days. So it's not recommended as a long-term, but maybe as a diagnostic test.
I absolutely agree.
And number two, Subbu.
Question to Chris. Is there any evidence that this cohort of patients who start in a younger age go on to develop symptoms of bladder outflow obstruction earlier on compared to, or is it completely independent? And do you kind of wait for these people to get to their late 50s and 60s to do a TURP to see if that makes a difference? We get a lot of people who've had a number of years of treatment, seen a lot of urologists, and then finally end up having a TURP quite earlier on.
Well, the evidence base for any sort of long-term follow-up is not there. It's likely that they have underactivity if they go into chronic retention. I personally would never want to do surgery just to see if it works unless I've counselled the patient very clearly and also have done a full urodynamic assessment. I think the evidence is that certainly if there's Detrusor function and you reduce the outlet resistance, you can certainly ameliorate the symptoms. But of course, with the underactive bladder, you have both storage and voiding symptoms, as I hope I've convinced you. And so I think just doing an operation, seeing if it works, gives the patients all the downsides of a TURP with retrograde ejaculation, etc., etc. So I think I'm very cautious, but maybe I'm wrong.
We do see lots of unhappy patients who've gone on to have TURP and continue to have symptoms. So I wonder whether there's any evidence.
But most of these patients, to my experience, don't do much better after the TURP. That's a problem.
Mark?
Thanks, 3 great presentations, but staying with the underactive Detrusor, there's been lots of anatomical studies done looking at the muscle in the older men with chronic retention, but has anybody done detailed anatomical studies on the bladders of these younger women who've got underactive bladders? Is there a change in the muscle?
A very good question, Mark, but to my knowledge, and I've reviewed the literature, there isn't any work in that area, but my colleagues may know otherwise.
There was only one work when I was at UCSF San Francisco that the gynecologists started to take biopsies and that there was a change, but it was never really published.
So gentlemen, at this point, I'm going to ask each of you a rapid-fire question for which I need a rapid-fire answer. So I'll start with Mark Schneider. Novartis was the one company mentioned in the Human Genome Project paper, which came out in Nature now a while ago. How come such a company which has invested heavily in genomics suddenly gave up on anti-no-go? Is there something that you're not telling us? Is it going to be very exciting in the next 3 to 5 years? Why did they stop?
So I think one of the biggest issues is at the moment that there was so much money pushed into neuroscience, but only very limited number of treatments which were then on the market, and it was a strategic decision to cut off the entire neuroscience block, at least in Switzerland. And so it was a strategic decision, and they are still in, so they will also earn money when phase 2 is successful, and they will kick in to phase 3 again. So it's not that they're completely out, they just said, we won't give you money to go on with the phase 2 because of strategic decisions.
So Katie, is tibial neuromodulation, the way you do it minimally invasively, going to wipe out sacral neuromodulation with a 50% failure, 30% revision rate?
I think it will give us a new opportunity to look into ways to modulate malfunction. We will have the opportunity to see what is really necessary, how much of a duration of a stimulation is needed, because we will not continue like 24 hours, 7 days a week. And therefore we will identify those patients in a different way which have the benefit of tibial nerve stimulation. But I think that we will keep sacral nerve modulation as a part of this package.
And finally, Chris, prostaglandins were a failure for Detrusor underactivity in the late 80s, as far as I can recollect. Why are they going to be any different now? Is there something new? Are the new products going to be more targeted? Is there something new that you didn't tell us?
The point is that there are various subtypes, and basically looking into the pharmacology of it, Karl-Erik Andersen's done a lot of the work in this area. There is the potential for stimulating it more effectively than an intravesical installation because of penetration through to the right layer. So giving something systemically, there may be benefit. It is hypothetical at this stage because there isn't decent human data, and the caveat that I gave was animal work, which has lent credence to this, has never yet led on to the development of anything effective in the human. So there's interest in this area, and it is an unmet need, but time will tell at this stage.
Gentlemen, you have been fantastic. Thank you for bringing the best translational science in functional urology to BAUS. Thank you very much.